Okay, this is the fourth part in pharmacokinetics. We're going to talk about hepatic metabolism or hepatic clearance. Now, the liver has two phases of metabolism, phase 1 and phase 2. It's pretty simple. The goal of the liver is to take a molecule that would be hydrophobic and to make it hydrophilic so that either it can be excreted in the bile or it can be excreted in the urine. So now hopefully you're seeing that if something is metabolized by the liver, it could be metabolized by both the liver and the kidney, or it could be metabolized by the kidney and the liver. They both work together. Or it could be metabolized solely by the liver and excreted in the bile, or it could just be completely cleared by the kidney. It could be separate. So let's take a closer look at the two phases of metabolism in the liver. Phase 1, you have oxidation, reduction, and hydrolysis reactions. These are usually done by the P450 system, so phase 1 is also synonymous with P450 metabolism, although there are a few reactions that are phase 1 that are not done by the P450 system. For example, alcohol dehydrogenase, the oxidation of catecholamines and histamine, and then esterase metabolism. For example, pravastatin and hydrolysis of procaine. These are all phase 1 reactions that are not P450, but these are the exception to the rule. The rule is that phase 1 metabolism happens by enzymes called cytochrome P450 enzymes. And by performing oxidation, reduction, or hydrolysis, I'm hoping to make my molecule water-soluble. It might become a little bit water-soluble, it might become very water-soluble, hydrophilic, or it might not change it at all. In that case, we can go to phase 2 metabolism. Phase 2 metabolism attaches things to my molecule. These are called conjugation reactions, and typically you're going to conjugate with something called glucuronic acid. This is called glucuronidation. This is by and far the majority of reactions that take place in phase 2 are called glucuronidation reactions, but you can also have methylation, sulfonation, acetylation. You can add glutathione. So if you're attaching a large water-soluble group to your molecule, it is called a phase 2 reaction. The enzymes involved in these reactions, by and far in phase 1, cytochrome P450. There's also the flavin-containing monooxygenases and the epoxide hydrolases. In phase 2, by and large, you're going to be using the UDP glucuronidyltransferases, but there's also the sulfotransferases, the N-acetyltransferases, the methyltransferases. But if you're looking for two things to remember P450 and remember UGT, or UDP glucuronidyltransferase. So P450 is a superfamily of enzymes that are named cytochrome P450 is because whenever you shine the light in them, the absorbance is at 450 nanometers. So this is a superfamily, and the superfamily has a certain way of naming itself. So the superfamily is named by all the molecules in this superfamily start with the prefix CYP or CYP. Then it has a number that will give the family. This is family specific, so we got superfamily, family. Then there's a letter that gives a subfamily, and then so another number would give the specific isozyme, so 3A4. The majority of the CYP450, cytochrome P450 enzymes are in the liver, but you have to know there are many others. Some are located in the intestine, some are located in the lungs. So anywhere you might have interaction with toxins from the outside world, you're going to have cytochrome P450 enzymes there to break down and destroy those toxins. There are some cytochrome P450 in the skin, but it's very little because your skin, the keratin forms this water-proof layer around your body, and so you don't need to really protect yourself from toxins unless they are hydrophobic and they can penetrate this water impermeable barrier. So you have a little bit of cytochrome P450 in the skin, not very much. So if you just think anything that has contact with the outside world, that's cytochrome P450, and then the small amount that is left, the really tiny amount of P450 that is left in your body, is going to be all within the mitochondria of every single living cell in your body. So the mitochondria have cytochrome P450 as part of the electron transport chain. And most P450 enzymes have a heme-bound iron molecule. This is important because if you are administering a drug that activates the production of cytochrome P450 enzymes, and you're doing that to somebody that has, for example, porphyria, this can have a major effect. This can cause them to have a crisis. What am I talking about with this crisis? Let's look really quickly at the heme synthesis pathway. So you start out with succinyl-CoA. The enzyme ALA-Synthase with the vitamin B6 are going to form delta-aminolevulinic acid, or sometimes it's called 5-aminolevulinic acid. That is acted on by ALA-dehydratase, or ALAD, to form porphobilinogen, hydroxymethylbilane synthase to hydroxymethylbilane. Then you can either go non-enzymatically to uroporphyrinogen 1, or you can enzymatically metabolize that to uroporphyrinogen 3 down to coproporphyrinogen 2, so that is metabolized by this uroporphyrinogen decarboxylase that catalyzes this reaction and this reaction. And then, of course, you keep going down. Ferrochelatase is the last step, and it forms heme. So there are 8 enzymes in this pathway in the synthesis of heme. And we know that every cytochrome P450 enzyme, not every, but almost every cytochrome P450 enzyme is going to have a heme molecule with iron attached to it. And so whenever you talk about heme, 80% of the heme in your body is in your blood. Your red blood cells is where it's produced. About 19.9% of the heme is produced in the liver for the cytochrome P450 system. And the rest of the heme, that last 0.01%, is produced in the mitochondria of every other cell in your body. That's for the mitochondrial electron transport chain. So here is the big breakdown, the scheme of heme synthesis, and you should know that a defect in any one of these enzymes can cause porphyria. I won't go into everything that porphyria is and what that all means at this point, but I just want you to know that it can cause porphyria. And where I have yellow, that is called a hepatogenic porphyria, and where I have red, these are erythrogenic porphyrias. So some porphyrias are mainly focused to be caused by metabolism within the blood cells, and others are mainly with metabolism inside the hepatocytes. And so you can see, for example, if you have a defect in ALA-Synthase, that can cause either X-linked protoporphyria or X-linked sideroblastic anemia, depending on which way it goes. And I have written in red all of the different things that can be, all of the different porphyrias. They're all basically abbreviated here, but everything that can be caused by a defect in each enzyme. Now here's where it gets really important. So the ALA-Synthase, this very first enzyme in the pathway, there's 2 isoforms. There's an isoform 1 called ALA-Synthase 1. This is a housekeeping isoform. This is the isoform that's used for every mitochondria in your body. This is also the isoform that's used to make the heme for the cytochrome P450 system in your liver. On the other hand, the erythroid isoform, this ALAS type 2, this is only found in the red blood cells. Its job is to make heme for hemoglobin. These 2 enzymes act completely different on feedback. So ALAS1 is feedback inhibited by heme. ALAS2 is activated by iron heme. So if you have somebody that has an erythrogenic porphyria and they get excess iron or excess heme, then it will cause a problem. It will cause the pathology to manifest itself. On the other hand, if somebody who has a liver, a hepatogenic porphyria, and they get administered, it's a drug called Heme, which is basically synthetic heme. That is how you treat the disease for hepatogenic porphyria. But there are a number of drugs you can give somebody that will cause the induction of cytochrome P450 enzymes. It will cause all of the genes to start being transcribed for the entire pathway. So it will upregulate heme production and it will exacerbate their porphyria. And so I'm saying all that just to give you one example out of probably hundreds of examples I could have given you, that there are different requirements for pharmacologic requirements for different diseases, and some things can be complicated by the disease itself. So if somebody who had porphyria, hepatogenic porphyria, if they also had tuberculosis, I would not be very hardy about putting them on rifampin. Rifampin is a CYP inducer, and it would cause their porphyria to become exacerbated. So here basically I restated that the CYP450, CYP is the name of the superfamily, the number represents the name of the number of the specific family, and then the letter is the subfamily, and then the specific isoform is represented by that last number. And so there are more than 50 cytochrome P450s that have been discovered inside the human. But if you want to get down to the most important ones, you just have to know 6 of them. And I'm saying 6 of them because there are a lot of them, but most of them have one substrate. For example, CYP19 has aromatase. It is the aromatase enzyme. It has one substrate, and that is the androgens, and it will convert the androgens into estrogen. Now this enzyme, this cytochrome P450, can be blocked by other drugs, for example, maybe like ketoconazole, but it cannot metabolize those drugs. It doesn't act on them. It can only be blocked by them. They have, for example, the aromatase inhibitors that are made specifically to do that, to block that one enzyme. But the pharmacologically important cytochromes are the ones that act on most of the drugs. There are 6 of them that will metabolize over 85% of your medications. So the CYP3A4 and 3A5, CYP2D6, CYP2C8 and 2C9, and CYP1A2. Now I think grouping helps for memory, so if you want to do it like this, CYP1A2, CYP2D6, and then CYP2C8-9, CYP3A4 and 5. Or you could even just mark these off and just remember that your last 2 have 2 numbers at the end. So I've shown the relative percent of drugs that are metabolized, the relative percent of the importance of each of these groups. And so you can see just these 6 make up 86%. And then you can get almost to 100% with a few others. For example, CYP2C19, 2E1, 2A6, and 2B6. Now, all the textbooks are going to say that the genetic variability in these enzymes is really important. That's true, it is really important. But right now, we don't have a really effective, cost-effective way of measuring that. And so it's not going to be something that's clinically useful in the near future. In the, looking 5 or maybe even 10 years down the road, I'm sure that this will be something that is profiled on a regular basis for each patient. There are some people who are considered fast metabolizers, for example, and they may need to have their dose increased or their frequency of dosing increased in order to keep a good therapeutic dose of the drug. Now, since we're talking about these enzymes, you need to know that the enzymes can be inhibited and they can also be induced. When you have a drug that is metabolized by only one of the cytochrome P450s, and you are taking another drug that is only metabolized by that same cytochrome P450, then those 2 drugs will interfere with the breakdown of each other. Now that doesn't usually happen because most of the drugs you're going to take are going to be metabolized by more than one cytochrome P450, so more than one isozyme. And that's what I've written right here, so you're going to have most drugs metabolized by multiple CYPs. But where you have problems is where you have a drug that will inhibit multiple cytochromes. For example, omeprazole can inhibit 3 of the cytochrome P450s that are involved in warfarin metabolism. So what's going to happen if the warfarin is not broken down? You're going to have increased warfarin levels, and you're going to have an increased INR, and you're not going to know why, but it's from taking the omeprazole. So you can see from this, warfarin is one of the, I would say, one of the 4 drugs that are metabolized by the P450 system that are commonly interacted because of these inhibition and inducer effects. There are also natural substances that inhibit cytochrome P450. For example, grapefruit juice is a potent inhibitor of CYP3A4. Other natural substances that interfere with cytochrome metabolism include St. John's wort, milk thistle, a bunch of things, and the way they interact will be different for each one as well. Now, induction is another phenomenon that happens. Induction happens via 2 mechanisms. So there can be an induction where, normally you have a certain amount of cytochrome that's being produced, and you have a certain amount that is being broken down, and the amount produced is equal to the amount broken down, so it stays in this stable concentration. There's a stable amount. And if you prevent this breakdown, you basically stabilize the P450 system. That will increase its concentration, it will increase the amount that's there, and it will increase the breakdown of drugs. In essence, if you induce P450, it's going to cost you more to treat your patient, or it's going to cost the patient more to afford their medication, because they're going to have to take more medication. The other thing that can happen is you can, instead of stabilizing the product, you can actually induce to cause more product to be made. So this is where you get down to things like nuclear factors. And I'm going to give you an example of how these nuclear factors work. What you need to know is there's two big families. There's the aryl hydrocarbon receptors, AHR families. These can induce the transcription of CYP1A1, 1A2. And omeprazole is a ligand for the aryl hydrocarbon receptors. The aryl hydrocarbon receptors, if you know that some people, let's say for example smokers, if smokers have a hyperinducible aryl hydrocarbon receptor, then they'll produce a lot of these enzymes, and these will break down some of the products of the smoking into carcinogens. It actually turns this, most of the time we're trying to take something bad and make it not bad anymore. We're trying to inactivate it in the liver. But in this case, you actually are turning the hydrocarbons into a carcinogen. And that brings about another point. Metabolism in the liver can do one of three things. It can activate a drug, it can inactivate a drug, or it can remain neutral. Some drugs are designed so that they get metabolized in that first pass metabolism. That actually turns them on, that activates them. Okay, so back from chasing that rabbit. So what we need to know is that there are aryl hydrocarbon receptors. There are the steroid hormone receptors, for example, pregnane X receptor, constitutive androstenedione receptor, the peroxisome proliferator activator receptor, the PPARs. There are several subgroups of the PPAR receptor that are medically important. For example, fibrates is one of the pharmacologic targets for the PPAR receptor. Now, what you're going to find out is a lot of these X, so you have a receptor that has an X in the middle. For example, PXR, the pregnane X receptor. These X receptors are typically, a lot of times, going to interact with the RXR receptor. So it's going to be, the pregnane X receptor is going to bind with the RXR receptor. There's a lot of these different X receptors. You're going to see them. But in this case, we have our ligand, atorvastatin. It's going to bind to the PXR receptor. That's going to cause it to combine with the RXR receptor around the genes to be transcribed. And in this case, we're going to make CYP3A4. You can see every protein that was needed got recruited by these two getting bound by the receptor. So for example, this coactivator, the TATA binding protein, the RNA-P2, all of it came in and it did its thing. So here is a list of ligands, receptors, so for example, the aryl hydrocarbon receptor, we already said omeprazole, the constitutive androstenedione receptor, phenobarbital. So all these things, these are not super high yield, but just being aware of them and cognizant of them is helpful. And that's because this is the mechanism of inducers of the P450 system. Okay, I'm about to give you a big list of things that I think are high yield to remember, but before I get into that, I'm just going to give you this. This is the website you can go to if you're more interested in the genetics of the P450 system. Like if you know you have a certain genetic mutation, you want to see how that's going to interact with a specific drug, then you can go to this website and you can look it up. So here is a list of P450 inducers, P450 inhibitors, and P450 substrates. So the P450 substrates, the really four important ones. We have theophylline, warfarin, and oral contraceptives, and anti-epileptics. As a class, anti-epileptics. As a class, oral contraceptives. And then as a single drug, the theophylline and the warfarin. And I've given you mnemonics. Mnemonics you can find online, mnemonics you can find in first aid. Another mnemonic that you might use is Vicks face all over GQ, and the only thing that's left out on that would be ritonavir, which is really high yield. But Vicks face all over GQ, valproate, isoniazid, cimetidine, ketoconazole, sulfonamides, fluconazole, alcohol, chloramphenicol, erythromycin, amiodarone, omeprazole, grapefruit juice, and quinidine. There's another mnemonic in first aid with something like sickface.com or something. I don't remember exactly what it was, but it actually included the ritonavir in it, so it might actually be a better mnemonic. Okay, I can't adequately do hepatic metabolism without talking about Michaelis-Menten Enzyme Kinetics. Now, Michaelis-Menten Enzyme Kinetics, I've already done videos on Michaelis-Menten Enzyme Kinetics several years ago, but if you want to check those out, I'm not going to go into how to derive the equation, for example. I'm not going to get into the Edie-Hofstee or the Lineweaver-Burke. I'm not going to get into a lot of the mechanisms of inhibition. I'm going to talk about it just vaguely in a couple videos from this, but not in this video at all. So what is the equation? The equation is that the rate is equal to the maximum rate. So really we would say V meaning the velocity of the reaction, but it's the velocity of the reaction is the rate. So the velocity of the reaction, or the rate, is equal to the maximum the rate could be times the substrate concentration divided by the Michaelis-Menten constant plus the substrate concentration. So I went ahead and made a graph for you. I did this in Excel, and I set for the graph, I set the Vmax as equal to 10, and I set the Km equal to 25, and I took the concentration all the way out to about 1400. Now let me point out really quick that I could change the Km and leave the Vmax at 10, where that would mean that if I changed the Km and left the Vmax at 10, that would, let's say I increased it to, maybe like 200. That would change the graph to look like that. So it will still reach the maximum velocity, but it won't get there for a much later concentration. Now, high Km, you might say, oh, well, that would require a lot more, a lot more higher concentration of a drug to get to the maximum response, and that's true. But you also have a lot more control, a lot more fine-tuning whenever the Km is high. If the Km is low, you just add a little bit of drug, and boom, you're at the maximum, the maximum rate of that drug reaction. Now I want to point out here specifically, I'm talking about the elimination rate of the drug. We're talking about hepatic metabolism. So right at this moment, I'm saying that this is, the liver is using enzymes to break down a drug to get rid of it, and so the liver is using this Michaelis-Menten Enzyme Kinetics to eliminate the drug. But I also want to point out that most of the drugs are going to interact with enzymes and receptors. And because they interact with enzymes and receptors, the drug activity can be modeled using the same equation. And we'll look at how the Km is a model of potency, where a Vmax is a model of efficacy. But I'm getting too far ahead of myself. Another thing I could do is I could keep the Km the same. I could keep a Km of 25, but I could lower the Vmax. For example, I could model it so that this is like this, and so that my Km is the concentration where I have exactly half the Vmax, and I can keep that the same. I can lower the Vmax, so you can do anything. You can do any combination of things. Changing the Km does not mean the Vmax will change, and vice versa. Too deep into this because this is something you definitely studied in undergrad, and I don't want to rehash things that you already know. But really quickly, right here I have Vmax is equal to 10, and so what I want to do is show you, like right here I have 10, and that when I get to half of 10, that's 5. If I follow that over, half of my Vmax, the substrate concentration required to get me there, that is called my Km. So Km is equal to the substrate concentration when the rate is equal to half of the maximum rate. And here I've just remodeled that again. And what I've done here, just so you know, this line is still ascending. I've zoomed way in on the beginning of that first curve that I showed you earlier that went out to like 14,000. This line is still rising and approaching 10. So I'm not just, saying that it's 10. This really is the same graph. And so here I've showed you again, I can alter my Km and leave my Vmax the same, and it just kind of stretches things out a little bit more. Get 100% response. then I want to, if I'm trying to get just 100% response, then, who cares what dose it is, right? But if I'm trying to get, let's say, 80% response or 70% response or some other percent response, it would be really hard to do using, the Km up here. But if I had a Km much, much higher, fine-tuning is easier. And so what is Km? I'll remind you, Km is literally, it's telling me how easily does the drug and the enzyme bind together. Do they seek each other out, or do they just kind of randomly bump into each other once in a while? Now, at very, very low substrate concentrations, my denominator will simplify. So whenever Km is very high, or whenever Km is much, much greater than the substrate concentration, then this is like saying Km plus almost nothing. Km plus almost nothing is almost Km. So what I'm saying is that at a very, very low substrate concentration, I get this simplification in my reaction rate. And I can rewrite the equation like this, and now it's looking very familiar, right? It's looking like the rate is equal to some constant K times the concentration of my substrate. Now this is first order rate law. And so what I'm saying, you have to understand what I'm saying here, that if my Km right here is 200, which it is, then if I'm way down here in this concentration range right here, then my rate is modeled by first order mechanics. And what if my concentration is very, very, very high compared to Km? If the concentration is way, way higher than Km, then Km plus a whole lot is almost like just saying a whole lot. In other words, my denominator simplifies to Vmax times C over C. And you'll know that that would easily cancel out, so my rate approaches Vmax. So when the concentration is much higher than Km, the denominator reduces to the concentration. So in this situation, I get that the rate is equal to Vmax, or the rate is equal to some constant, just some constant. This is zero order kinetics. So now I can model my reaction at low substrate concentrations as first order kinetics. At high substrate concentrations, my reaction is modeled by zero order kinetics. And I've basically just written that here, high concentrations, zeroth order, and there it is right there. There are really only a very, very small number of situations where you're going to be modeling your clearance at zeroth order. One of those situations is alcohol metabolism. So you'll know that if you drink, let's say, 8 beers, it doesn't matter how many, if you drink 9, 10, 11, 12 beers all in an hour, you're still going to lose the same amount of alcohol out of your system each preceding hour after that. So it's usually about 1 drink metabolized per hour, and it doesn't matter what the alcohol concentration is in your system, it's going to metabolize at about 1 drink per hour. The other situation where you get sort of a zero order kinetics is during first pass metabolism. First pass metabolism, this drug concentration, whenever let's say you've taken a pill, the drug concentration going into the liver is very, very high, much higher than what it would be for, it would saturate many of the enzymes. And so that first pass metabolism, it's going to model first order mechanics, but afterwards you've already taken out a lot of the drugs, so there's not much left in your body, but it's also diluted by all the blood, and only a little bit, tiny bit of that is going back into the liver each time it goes through your system, and so you have a tiny concentration going through. It's modeled by first order kinetics. And so just a reminder, we're talking about clearance right now. So total body clearance is going to be equal to the clearance of the liver plus clearance of the kidney plus clearance of any other system plus. It's going to equal the total clearance. And in general, we can model this total clearance by first order mechanics. Now, I'm going to go back to something that I didn't touch on previously because we hadn't talked about first pass metabolism quite extensively enough, but that is something called loading dose. And we know if we start somebody off on a maintenance dose of something, if we just give a dose and we keep giving that same dose, eventually we'll approach a concentration steady state that's up here. But what happens if getting up here is going to take too long? What do you do? If it's going to take too long, then you give a loading dose, and then you move back to your maintenance dose to maintain that concentration. And I've shown basically what that will look like on the graph over here if you give somebody a loading dose. So loading dose is really easy to calculate. It's something that you don't even have to think about at this point, because you know that the total volume of distribution, so you know that, let's say the concentration of a drug is going to equal the mass of that drug divided by the volume that it sits in. So the mass, this is going to be the total, the input, right? And the volume is going to be my volume of distribution, VD, and this concentration, this is my target concentration. My target concentration is the same thing as the concentration steady state that I'm really wanting. And when I ask myself input, what is the input? That is the dose I'm given, times the bioavailable fraction. So when I ask what is that dose, I just multiply the bioavailable fraction to the other side of that equation and get concentration steady state times the volume of distribution divided by the bioavailable fraction. And that's how you can dose somebody if you're looking to get them up to that target concentration quickly. And how do we get there? We just simply use the concept that mass divided by volume equals concentration. This is stuff we learned back early in general chemistry. Mass over volume equals concentration. And then I've already explained maintenance dose, how to get that. We've already talked about how to calculate a maintenance dose, for a specific concentration steady state. Remember, we said that we go input equals output, where output is equal to the volume times the concentration. So I'm talking about the mass, how much mass is leaving. So how much mass is output, and we can say, remember that mass divided by volume, yes, is equal to concentration. So my mass leaving is equal to the concentration times the volume. The concentration times the volume is the mass leaving, and I want to set that equal to the mass coming in. And the mass coming in, remember, is going to be equal to the dose times the bioavailable fraction. Now I modeled that as a single dose. Now you can remember that we can model that as multiple doses over time. That's called the dosing rate. The dosing rate is equal to the dose divided by the dosing interval, or I. You remember the dosing interval is equal to the time divided by the number of doses. So over 24 hours, 3 doses, that means the dosing interval would be 8 hours. And you would put that as 8 hours per dose. So what I can do is I can divide this variable volume by time. I can divide my dosing variable by time, and we know that gives me the dosing interval by doing that. And so I take my concentration. What is the concentration? It's concentration steady state. And what is this volume over time? Volume over time is called my flow rate, or my clearance rate. So this is times clearance. And so concentration steady state times clearance is going to equal the dose over the dosing interval times the bioavailable fraction. And so that's how you calculate your maintenance dose. I'm just reminding you these things. This is something you've already learned. The only thing I really want to hammer home is that the fact that the loading dose is where you set the concentration. So you say that there's a mass over a volume. You set that concentration. This is going to equal the concentration steady state, or in other words, my target concentration. And then so you say the volume, what is that? That's the volume of distribution. And mass, what is that? That's the mass, that's the inputs, that's the dose times the bioavailable fraction. And that is literally how you calculate the loading dose.